So we're going to be talking about eating disorders and diabetes today. And how many of you have heard the term dia-bulimia? Okay. 2 years ago, maybe one person would have raised their hand. And I've been doing this work for about 10 years, seeing patients, primarily treating women and teenage girls with this problem. But I had this strange experience where Joslin Diabetes Center, as Bill said, because we're pretty well known in the area, we get a lot of publicity calls, and sort of journalists call us and ask, we have a communications department, will you please speak to so-and-so about whatever? And they know that I pretty much will talk to anybody about anything, and so they always field anything that has anything remotely to do with emotions, they throw my way. And this one actually happened to be about my area, so I was even more excited. But the guy, I somehow missed something, and the guy was asking me for like a local Florida story, like did I know any patients in Florida who were struggling with this? And so somehow I thought it was like a local newspaper story in Florida, and it turned out it was this, and he's actually works for the Associated Press wire service, and a day after it was published, it was on 900,000 newspapers across the world, actually. And so I sort of had the funny experience of Googling myself, and I was in China, and these very strange things. So, so the term dia-bulimia, as I hope you know, is actually a term that's been created by the press. It's not a term that I really agree with, and it's actually a term that I have some issues with, because number one, my brother makes fun of me about it because he thinks it sounds like diabolical. And what kind of nonsense is that? I'm not a real doctor, I'm only a PhD. He has the MD, so he just likes to throw that around. And also because I think it runs the risk, actually, of reducing this problem to one problem, when in fact what it is two very distinct chronic diseases, namely an eating disorder and type 1 diabetes. And I'm mostly going to be talking about type 1 because that's where my research is, although I do a lot of work with eating issues and weight issues in type 2, so I'm happy to answer questions about that as well. But this phenomenon is primarily understood in type 1 and has to do with the intentional manipulation of insulin doses for the purposes of weight loss through hyperglycemic calorie purging. So women and girls intentionally skip insulin shots or underdose insulin shots, run their sugars high, and lose the majority of their calories in their urine through glycosuria. So what I'm going to do tonight is talk to you about eating disorders in general. I haven't found sort of a pithier way of explaining that, so I call it eating disorders in general, because what I mean is eating disorders not in the world of diabetes. And then I'll talk also about some possible connections between eating disorders and type 1 diabetes, and the talk primarily focusing on case examples and treatment strategies that I've found helpful. And hopefully we can discuss some of your own cases, because I think that's really where the rubber hits the road and where people are more interested. So I just have this little disclaimer at the beginning, which is that the connections between eating disorders and diabetes that I will be discussing are primarily derived from my own theorizing, but strongly informed by the research and writing of my colleagues in Toronto, Drs. Gary Roden, Patricia Colton, and Marion Olmstead, who are really the leaders in this field. My discussion of treatment strategies will be rooted in research on eating disorders outside the context of diabetes, naively creative clinical interpretation, witchcraft, and voodoo. Because largely, we don't know how to treat this population. And so the task at hand is really to look at the eating disorders research and the eating disorders treatment research and try to understand, okay, how do we take what's known and understood about treating eating disorders and uniquely tweak those strategies to tailor them to the specific needs of women with type 1. So anorexia nervosa is the refusal to maintain body weight at or above minimally normal weight. So these are the sort of classic stereotype when you think of eating disorders. You see this very emaciated, waif-like image. Anytime I'm in the airport, I see these on all the tabloid magazines, the latest Hollywood starlet struck down by an eating disorder. And it actually has sort of the mythology that this is a sexy, sort of spectacular, Hollywood, fabulous kind of lifestyle. And I think what's missing there is that this is actually a psychiatric disease which causes tremendous pain and heartache and massive torment to the person and their family members and their loved ones, and major medical problems. So these are the women who have intense fear of gaining weight, even though they're already at a very low body weight, and actually have sort of a distortion in their self-image, where what they're seeing in the mirror is something actually very different than what we're seeing when we're looking at them. So they can point and show you, I have fat right here, I have fat right here, and they perceive themselves very differently than how we're actually seeing them. It also happens to have the absence of at least 3 consecutive menstrual cycles, because the female body at such a low weight is not a safe body to have a pregnancy. So body sort of conserves energy and doesn't have a menstrual cycle. Bulimia nervosa is very, very connected in the underlying thought process and the underlying sense of self that women with anorexia struggle with. But bulimia nervosa, these women are typically either normal weight or slightly overweight. And so these are actually the unseen, unrecognized people who are struggling with an eating disorder. And this is actually where the majority of patients with type 1 may land diagnostically, but we'll talk about that a little bit more. So this is where there are recurrent episodes of binge eating, which is very different than the kind of eating you guys are doing right now. Binge eating is defined as eating a larger amount than your peers would, but it has to be accompanied by a sense of loss of control. And so there's this sort of psychological aspect to it, that it feels like chemical reaction has started and the person is completely out of control of the behavior. And I think the question that this particular little piece of the diagnosis really begs is, what is the peer group when you're talking about someone with type 1 diabetes? How do you define a binge in the context of type 1 diabetes? Is that any deviation from the meal plan? Is it overtreating a hypoglycemic episode? Is it eating the same as your same age peers without diabetes, but that's actually overeating for them, but it's binging for you because your blood sugars go higher? It's totally confusing, I think, in this particular arena. And so we don't really know how to define binge eating in type 1. But connected to that, there has to be calorie purging. And in bulimia nervosa, most typically what people think of is self-induced vomiting or possibly laxative abuse, maybe compulsive overexercising. But the area for type 1 diabetes, in the early 80s, you started to see a lot of research that was basically an academic debate between psychiatry and this sort of very categorized diagnostic criteria and people who were actually treating women with type 1, who were saying, we've got these women who are running their sugars high, they're running all sorts of medical risks, developing complications early, they have an eating disorder. And psychiatry was saying, no, they don't, because it can't be purging, it's not vomiting, it's not laxative abuse, it's not compulsive exercise. And it's not until DSM-4, which is only 2 DSMs ago, which is our Diagnostic and Statistical Manual, that they actually included the misuse of other medications as a symptom of bulimia nervosa. And so in other chronic disease states like thyroid disease, you have manipulation of thyroid medicine. In other disease states like cystic fibrosis, you have manipulation of the pancreatic enzymes as a means of calorie purging. And in our case with type 1, selectively or intentionally underdosing or even skipping insulin doses to produce hyperglycemia for the purpose of calorie wasting into the urine. And so Then you get into the sort of persnickety has to happen this many times per week in order to count as a diagnosis. But what's really fundamentally similar is that whether you're talking about anorexia or bulimia or any kind of eating disorder, these are women whose sense of self is defined by their body image. And there's no, you can never be too rich or too thin. They can never be too thin. Eating disorder NOS. NOS means not otherwise specified. This is actually where about 75% of patients with eating disorders land diagnostically. And if you look at the eating disorders research, it's all this very squeaky clean academic research where it's looking at pure categories of anorexia nervosa, pure categories of bulimia nervosa, and not this sort of slightly blurry hodgepodge of it's a really low weight person, but occasionally she binges and maybe she purges sometimes, but not at the same level of frequency. And it sort of runs the risk, this is where the majority of patients actually are, but by calling it NOS, not otherwise specified, sort of implies that it's this not really clinical category. And it's absolutely not true. Eating disorders are very medically compromising, and they are that whether they're NOS or bulimia or anorexia. So here's the prevalence, and this is outside the area of diabetes. Anorexia nervosa affects between 0.5 and 1% of late adolescent and adult women. I mostly speak about women actually during this talk because we'll get to it a little bit later, but the ratio of women to men with eating disorders is 10 to 1. So the majority of patients are in fact women. Bulimia nervosa is twice the rate of anorexia, between 1 and 2%. And then here's the EDNOS, is what they call it, eating disorder not otherwise specified, which is, again, you'll see at a much higher rate. And that's only in college-aged women, 10%. But again, there used to be this idea in the eating disorder scientific literature that this was primarily an adolescent and young adult woman's problem. And what we've learned is it's more like a chronic vulnerability that follows women into adulthood and into middle adulthood and probably into older adulthood as well. So approximately 1,000 women die annually of anorexia nervosa. It's the most lethal psychiatric disorder that exists. Over 5 million Americans have eating disorders, and 15% of young women have what's called substantially disordered eating. So this is the problem where, as a researcher doing this kind of work, part of what you need to do when you're trying to study a phenomenon is you need to find a normal control group, right? So you need to find women in the United States who don't have problems with their body image. Good luck, right? So, okay, so this is what my mentor from way back in college she wrote this landmark paper a million years ago called Women and Weight, a Normative Discontent. And what her point was is that you can't find women in industrialized nations who don't struggle with body image. Even the top fashion models will say, oh, there's this little pocket right here on my left thigh where I wish I could, shave something off. They're airbrushed. So it's really hard. This has become a normalized anxiety. But there is this blurry boundary between body image disturbances and eating concerns or eating issues, struggles with eating disorder, sort of sub-threshold symptoms, and then going further along the continuum toward eating disorders that actually create medical risk. And I think in the context of type 1 diabetes, it becomes very, very complicated because even at what we would normally consider a sub-threshold kind of symptom picture, we know that it causes medical risk. So women who occasionally skip insulin because they have a fancy event to go to and they want to fit into a really important, fabulous dress, they're causing damage to their bodies. And that's what sort of in the non-diabetes world, people who do the sort of cabbage soup diet or something really crazy that's medically nonsense, but not at that same level of risk. So I think it's important to understand that within the context of type 1, even the sub-threshold symptoms cause risk and cause damage. So who is at greatest risk? We used to think it was primarily Caucasian women. Now there's actually some pretty good evidence to show that it's not really about being white, it's about being westernized. That it's primarily the industrialized culture and possibly media's role, who the heck knows what's causing this, but that women in most industrialized countries have this risk. 15 to 25 is sort of a typical blip in terms of where you're going to see the most new onset of eating disorders. And again, men to women, it's 1 man for every 10 women. And one of the precipitants is a pattern of rigid dieting. So here's where we start to see the initial threads of why women with type 1 might be at greater risk. So if you think about the ways that both the exchange method of meal planning or the carbohydrate counting method of meal planning, or even way back when, before the discovery of insulin, when it was the starvation method of meal planning, rigid dieting has been part of the way we educate patients with type 1 diabetes, and I think we need to think differently about that message. I think that needs to be more flexible. The concepts need to be less black and white, less good, bad, less moralistic, and we can get into that a little bit later. We know that when we talk about who's at greatest risk from sort of a hobby or professional standpoint, we talk about gymnasts, models, ballet dancers. In men, wrestlers and jockeys are at greater risk. And I think, again, if you think about chronic disease models where there's such an attention on weight and on eating, it makes sense that type 1 would fall into this category. So here are some of the possible connections. Puberty is a diagnostic peak for both type 1 and eating disorders. So you're taking a time of tremendous vulnerability for girls and sort of creating the perfect storm, if you want to think of it that way. Type 1 presents with initial weight loss, and oftentimes I've had patients talk to me about this initial sort of, they mean something different by the honeymoon phase. They don't mean sort of there's still some pancreatic function. They mean that they're not quite feeling as ill as they get later, but they're starting to lose some weight and they're kind of feeling sluggish and not so hot, but they're getting all this positive response from their friends, from their peers, from their teachers, from their coaches. You look great. What's your secret? And then it tips over the edge where they actually feel like their body's eating them alive. And now they wind up in the hospital, possibly with DKA, possibly not, diagnosed with type 1 diabetes, rehydrated, put on insulin. Their body regains to a healthy body weight, and they learn insulin made me fat, even though their body's actually returning to a healthy body weight, right? So there is some learning that happens right there at diagnosis. I'm not suggesting that that's exactly where the eating disorder starts. I don't believe that that's true, actually, but I believe that's where it starts for some people. Type 1 treatment involves attention to meal planning, as you all know. It involves attention to weight, to exercise, activity level. And in its worst caricature, I would argue that some diabetes education actually mirrors the mindset of an eating disordered person, assigning kind of moral qualities to food. That's good, that's bad, that's off limits. A chocolate chip cookie is crack cocaine, don't do it. Concepts of cheating instead of eating, those kinds of things. And then we also know on the flip side, even though weight is really a focus for some endocrinologists of their treatment, we know that intensive blood glucose control intensive insulin management actually promotes weight gain. So if you look at the DCCT data, you know that the intensively managed group actually gained 10 or 11 pounds more on average than the treatment as usual group. And that's a hard pitch to sell to a young woman who sees her pant size increasing and who's acutely aware of how her body is different than the ideal. So this is some of the research that was done in eating disorders and type 1 so far. So again, I mentioned to you that this original debate was, is it an eating disorder? Is it not? Is it a higher risk group? Is it not? And this study, Jones 2000, which came out in the British Medical Journal, this is from the Toronto group that I mentioned earlier. They really sort of set the record straight. They had a very well designed study, case controlled, same age peers matched, so girls and adult women with type 1, age matched to girls and adult women without type 1. And they found that the diabetes group had 2.5 times the risk of developing an eating disorder than the same age matched group. So that's pretty compelling research. Bill Polanski is one of the shoulders that I stand on, actually. He and Barbara Anderson at Joslin Diabetes Center back in the 90s collected some really interesting survey data looking at eating disorder symptoms and depression and anxiety and overall specific diabetes distress. And then created their own survey specifically asking about some eating disorder traits and thoughts and beliefs that might be unique to people with type 1 diabetes. They gave these surveys out to just women with type 1 who happened to be in our medical waiting room. They weren't hand-selected for having a mental health appointment. In fact, they were all there for just routine medical care. And look at the age range, 13 to 60 years old. So this is not the age range that we typically think of when we think of eating disorders. And 31% at the esteemed Joslin Diabetes Center admitted that they omitted insulin at some point in their lives. Now that is not to say that 31% of these women met diagnostic criteria for eating disorders. That is to say that 31% of these women openly acknowledged that they were willing to really play a very dangerous gamble in an attempt to lose weight at certain points in their lives. A similar gamble to the kinds of crazy things that women are willing to do when they buy those medicines and those sort of supplements out of the back of fashion magazines. They're not FDA approved, it's ephedra, it's whatever, who knows, hoodoo or something, there's some new, I don't know, crazy stuff, and they always have a Hoodia, is that it? Okay. And they always, sorry, not hoodoo. And there's always, it just sounds like voodoo, that's why. And there's always, the before and after, where the before the woman's really sad and pale and pasty white, and after she's tan and gorgeous and you can't even recognize her because she's been airbrushed. But so I think that's what's going on with this 31%. 9% admitted to using this symptom at a level of frequency that probably merited an eating disorders diagnosis. I'm using all of these very cagey, sort of half-hearted terms like probably and maybe, because we can't say that this was a questionnaire survey, but we're estimating that. And then in 97 and again in 2005, we've got papers in the New England Journal of Medicine and in Diabetes Care showing really once and for all that these symptoms are associated with earlier onset of microvascular complications at both younger age and shorter duration of diabetes. And so showing really that eating disorders in the context of type 1 diabetes cause medical damage. And then I looked at the same group of women, the 341 Joslin patients that Bill and Barbara gave those questionnaires to. My colleague Katie Wanger and I decided let's try to track these women down. And And we're pretty proud of ourselves, actually, because it was not designed originally as a longitudinal study. And so, 13 to 60. So a lot of these women got married in that time period. A lot of these women changed their names. A lot of them were college students in Boston, moved elsewhere in the country. We were able to track down 60% of them. And we found that admitting to restricting insulin at some point in your life conveyed a 3-fold increased risk of death during the 11-year follow-up period. That's really, really chilling data. And so that's the paper, insulin restriction and associated morbidity and mortality in women with type 1 diabetes. And my goal really in getting that message out there was to sort of end the debate and to really highlight, this is a high stakes problem. This is a women's health issue. This kills women, and we got to do something about it. And let's stop the kind of research that's focused on is it or isn't it, and if so, does it matter? Let's move the field forward to some treatment research and some prevention research, which is what we really need at this time. So we found 60% of the original cohort, and they were categorized as insulin restrictors. This is important. So this is not to say that they actually had an eating disorder. We can't say that because this is just questionnaire data. They answered a question for us that said, I take less insulin than I should. And if they said yes to it, we called them an insulin restrictor. That could be at any level of frequency, and we called them an insulin restrictor. And that crude kind of question still differentiated those two categories and showed such a higher risk of mortality. There was no difference in rates of death. So the non-insulin restricting group and the insulin restricting group, they had similar death rates, but the average age of those who died who were in the insulin restriction category was quite a bit younger. So 44 versus 58. And 40%, this tells you something about frequency and severity of the symptom, 40% of deceased insulin restrictors versus 7% of living insulin restrictors endorsed that they did it always. So it's so it really was a more severe group. But that's sort of the compromise that we were able to come at it to try to figure out diagnostically, was there something meaningful about frequency and severity? So really where I want to spend the time is how do we recognize these phenomena earlier? And when we do recognize them, what do we actually do about it? So what I'm going to give you are some sort of diagnostic sort of clues, and again, I'm calling them clues because there are many reasons why people may have a dramatic change in their weight up or down. There are many reasons why people may have a change in their A1C up or down. It doesn't mean that that is the smoking gun of an eating disorder, right? Just a couple clues to sort of raise your questioning, but there could be multiple factors at play. You have to be alert to falsified blood glucose data, but again, that's a very common behavior in teenagers with type 1 diabetes. That's the reason why blood sugar meters have memory, right? I mean, so we know that. So that again is not, the meter doesn't, the handwritten glucose log doesn't match the A1C. That person has an eating disorder. No, I want you guys to start thinking, more nuanced ways. There's multiple reasons why somebody may be having a harder time managing their diabetes, but this is a unique thing. Note patterns of repeated unexplainable DKA. Again, that could be a marker of chaos in the family. That could be a marker of homelessness and lack of medical care, or that could be a marker of an eating disorder. Inquire about irregular menstrual periods. Again, it's not a diagnostic perfection, yes, no, but oftentimes if women are running higher sugars in a chronic enough way, they'll skip their menses. And this is really the take-home message. I think so often family members, friends, coaches, and particularly medical professionals are afraid to ask these kinds of questions. So for a number of reasons. First of all, everyone's afraid of somehow teaching this symptom, right? And I think that's valid. Like we have to sort of ask these things in a more open-ended and sensitive way. But I think another thing is, it's sort of like when I was in my internship training and doing evaluations in the emergency room, and you'd have to ask questions about suicidality, and you'd sort of at the same time be closing your ears and going, please say no, please say no. And you know, you have to ask. It's really important. So, so you have to ask, how do you feel about your weight, shape, and body? Are you trying to lose weight? Are you currently dieting? Do you follow a meal plan? Is it hard to follow the meal plan? But bottom line, do you ever adjust your insulin in order to affect your weight? That's a very kind of neutral, I haven't said up, down, weight, up, down. I've done nothing. Or just ask the question we actually asked in the study. Do you take less insulin than you should? Now here's the problem with all of these questions. Everybody can say no to them. Right? And they can look you in the eye and say, absolutely not, something's wrong with my strips, the meter conked out, I have no idea what's going on, something's wrong with that lab that gave me the A1C. But by starting the conversation, you guys are showing that you're open to it, that you know about it, and that you want to know about it. Instead of sort of having this kind of stance, like you're not taking less insulin than you should, right? Which, you know, the answer, of course, to that is no. So what I found myself doing, Jocelyn's a really strange place to work, actually, because in some ways my role is that of sort of traditional psychotherapist. I see some people who are local. I can actually see them with sort of pretty regular frequency. But then we've got these patients who come to us because they've heard, you know, we're the best place in the world, and so they come to us from Venezuela or from Saudi Arabia or wherever, and it's a one-shot deal. You know, it's like meet the whole team in 2 days, have 1 hour with Ann Goebel-Fabry, and be done with your eating disorder. And you know, that'd be great if I could figure that out, because the HMOs would love me. But so what I started doing in those kind of single-shot consultations is I kept drawing this model for people, because I felt like I wanted them to have something they could take home to their medical team at home to start the conversation. And if you've ever seen a sort of proposed model of eating disorders in general, or frankly any psychiatric problem, the precursor, the top box, is always something biopsychosocial. So it's always something genetic or neurochemical, something wrong in the family system, there's abuse, there's trauma, there's who knows what, something social, there's disenfranchisement from society, there's women's role in society, there's the media influence, there's blah, 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 blah. And I'm not trying to belittle these things, but in diabetes, where I have to start is the treatment. So the diabetes treatment goals themselves teach, or have the potential to teach, to a particularly vulnerable patient, some of this eating disorders mindset, right? So we're emphasizing the importance of near normal glycemia. We need to emphasize that. That is important. But if you're giving that message to someone who's already an extreme perfectionist, they're going to take that ball and run with it and get very, very frustrated. We're teaching carbohydrate counting, which I actually think is a pretty reasonable tool. But the way that gets sort of translated through the mind of a vulnerable person who's already thinking about weight loss and dieting and already has some very rigid ideas about good foods and bad foods, I think can get morphed. And in a certain way, we do advocate portion control and dietary restraint, and we have to. But I think it's sort of how do we make this message a little bit more reasonable? Then we have to own up to the fact that intensive insulin management actually does run the risk of weight gain. Then you've got the extreme perfectionism and frustration that can emerge with blood glucoses that don't sort of map into that perfect 80 to 120 range, and frustration with weight. And then you've got sort of the feelings of deprivation, dietary restraint, and possibly the emergence of a binge purge cycle. So on the left-hand side, you've got symptoms of depression. On the right-hand side, negative feelings about weight and shape. And then at the bottom, this sort of cycle of hyperglycemia, elevated A1C, strategic insulin restriction for calorie purging. And for some people, it's not symptoms of depression. For some people, it's symptoms of anxiety. Who knows? We can, tailor that to the individual. But I found this model to be very helpful to actually review with patients and to then try to say, okay, here's what I think has been going on, and where are you ready to start to try to tackle this? Because I used to feel incredibly overwhelmed by the complexity of this and how everything intersects and overlaps, and hyperglycemia feels a lot like depression, and the lethargy that goes with that, and the irritability, and how do you dissect one from the other, and all this stuff and all this murkiness. And at one point I had this kind of aha experience where I realized, okay, it is very complicated, and in a certain way that's actually freeing, because if you're psychologically trained, there's this other theory called family systems theory, and the idea is the system is its own thing and everything influences everything else, and one change in one family member changes the whole system. And so one change anywhere in this complex web has the potential to sort of tip the balance and move things forward, or at least jostle things a little bit. And so that's how I try to sort of pitch it to my patients. This is a completely fake person. She doesn't exist. We are going to get into some actual real quotes from people. But Terra is sort of like a mishmash of probably, 60, 100 patients. For the sake of argument, she's 15 and a half years old. She's had type 1 since she was 6. And this is going to sound very familiar to you guys. At age 12, right around the onset of puberty, her blood sugars get a lot harder to manage, right? This is typical with all the hormonal changes of puberty. The hormones actually act as insulin agonists, and so you have a much harder to manage diabetes during puberty. And right at the point where it's developmentally appropriate that a kid like Terra should want less parental supervision and less parental involvement in her diabetes management, and her reasonably well-meaning parents are trying to let her individuate and are trying to let her become a little bit more sort of autonomous with her management, she's got a much harder to manage diabetes. So everyone's pulling back a little, and diabetes is worse. So there's less support for a harder disease, and she gets frustrated. So along with that frustration comes the occasional skipped blood sugar check, and comes the occasional skipped insulin injection, which who the hell wouldn't skip it? It's one more irritation. And positive comments start happening as she's losing weight, and before we realize that her A1Cs are climbing higher. So she's got this added bonus of not having as many hassles because she's taking a couple less shots, and there's this incredibly reinforcing and very, very powerful phenomenon that she's seeing incredibly fast and incredibly dramatic weight loss on the scale, and she's eating whatever she wants. And then the rubber hits the road because she gets her A1C drawn, and there's all kinds of conflict, and conflict not only within the family, but also conflict within the medical team, and some disengagement from healthcare, and now we're in really big trouble. So on the left-hand side, you see weight, and the yellow bar is her weight, and on the right-hand side, you see A1C, and the red bar is her A1C. And I actually do this with patients. And I found this to be most helpful. I don't do this with every patient, but I found it to be most helpful with the kind of folded arms, I don't know, nothing kind of response teenager. Do you know these kids? How's your diabetes going? I don't know. What do you want to talk about? Nothing. Right? Well, why are you here? I don't know. People think I'm crazy. Put me in the shrink's office. And I'll just sort of, this worked a lot better when we had a paper chart, but so I would flip through and we'd actually draw this kind of timeline and we'd sort of map it onto, so what was going on when you were 12, when that A1C started going up? What was going on in your family? How did you feel about diabetes at that point? And sometimes this is a conversation starter. Or, gosh, look at the inverted relationship between your 14% A1C at age 13 and that really, really low weight. How'd you feel? And then you start to see over time, maybe the relationship becomes less clear. So this is where it starts to get really murky, and you actually do see this a lot, that you can have the high A1C, but the eating becomes so voracious because of the high sugars and the actual sort of cellular bodily starvation that's going on, that people can eat in such a dysregulated way that even the high blood sugars don't maintain very, very low weight. And so sometimes you start to get this sort of disconnect between the high sugars and the weight. And so you see that a little bit with Tara, and you also see the 2 episodes of diabetic ketoacidosis, which is the profound risk for most of my patients and for most young women or women of all ages who are struggling with this problem. So I thought it would help sort of enliven the discussion to actually look at the way some patients actually talk about this problem. And this is not my patient. This is a woman named JJ who was a patient at the Joslin and actually was one of the study participants in the study that I did, the follow-up to Bill Polonsky and Barbara Anderson's research. And JJ died at age 24, and her mother volunteered at the Joslin and learned about my research and has been very, very involved in supporting this work and in trying to get the word out about this problem. And so she's been willing to speak with Boston Globe and USA Today and CNN and other media outlets when they ask me, can you give me a patient to talk to? I never give a patient to talk to, but she's been willing to tell her own daughter's story. And she gave me JJ's diary, and this is a quote that actually was in the Boston Globe, so I feel comfortable sharing it with you guys. I know it's not a lot of weight, but 12 pounds in 2 weeks is drastic and uncomfortable. This is right at the point where JJ was trying to take better care of herself. So she was giving herself insulin, and she was getting some of that swelling that happens, that insulin edema that happens when your body goes from profound dehydration to rehydration. So I know it's not a lot of weight, but 12 pounds in 2 weeks is drastic and uncomfortable. I haven't taken my insulin now for a day and a half. I feel too fat. Hopefully by tomorrow, I'll feel thinner and have the strength to continue my insulin program. And she signs this particular diary entry with her weight. And in a day and a half, it's 4 pounds lighter than that 12-pound weight gain. So you can see, again, this is very dramatic and incredibly reinforcing behavior. And then JJ's mom wrote, "It's become clear to me that the message I've conveyed, you will die, but that's not the worst thing that will happen, is not helpful to women who are actively practicing this behavior. I think that I should change my message to don't start because you may not be able to stop. As a result, I believe that awareness and prevention is just as important an issue as treatment of insulin restriction itself." And again, I completely agree. And I think this is another area that we really need to start paying attention to. But at the very least, early intervention and early detection is possible if more clinicians are willing to sort of have that conversation with patients. This actually is a patient's story of a lasting recovery. I began to change slowly. I had learned over the years that any action that needs to be done for the rest of my life must fit into it. I'd finally made a change in my life and sustained it, and it felt good. Actually, it felt incredible. So I chose to make another change and then another, and these changes soon added up, and now I'm happily living the benefits of my concerted efforts. And I love this quote because if you think about incremental changes along the way, that's exactly what we actually need to encourage our patients to be willing to try. And that's exactly the treatment tactic that I'll talk about when we get to the next slides. And it's actually what the DCCT data show us, right? So they show that with every 1 point decrease in A1C, you shave off risk of complications. And so rather than fixating totally on 7% or below as this sort of diabetes nirvana, I think what we have to focus on with these patients in particular, but probably with most patients, is incremental change and moving forward. And how much better their bodies feel when they move from 10% to 9 or from 9 to 8. She goes on, with improving my blood sugars, blood lipids, and blood pressure came significant and considerable benefit. My kidney function went from full-blown clinical albuminuria to normal function. My feet, which used to be virtual icebergs, now maintain healthy warmth. I had sustained proliferative retinopathy and in 1997 had laser surgery on my eyes. My ophthalmologist has told me for the past consecutive 6 years that not only are my eyes not getting worse, they are healing and improving. And we actually see this. This is not just one woman's story. She happens to articulate it in a really great way. But so I think that's the message that we need to be able to convey to patients, and that's somehow the message that has gotten lost in the DCCT data, actually. So when we talk about treatment of eating disorders, one of the gurus happens to be this guy, Dr. Christopher Fairburn. He created this cognitive behavioral therapy primarily aimed at bulimia nervosa, but now it's aimed at all eating disorders. And what he starts with is establishing regular and flexible eating patterns and eliminating dieting and food restriction. So he starts right there. And what he actually articulates is have a planned breakfast, lunch, and dinner, and snacks in between. Don't allow yourself to become so deprived that a binge gets triggered. And if you flash back to the old style meal planning that we used to give as education to patients with type 1, it sounds actually very similar. And it turns out if you give your body some nutrients across time, across the day while you're physically active, your blood sugars are somewhat smoother and you're less triggered to binge. And so that's the fundamental starting point that I try to work with my patients on, at least from the meal planning perspective. And frankly, I don't really care, and he doesn't care either, what they're eating for those meals. So in the beginning, we just start with, let's have meals. And then we get into more of the nuances. But initially, it's about let's establish a routine. And then we also talk about developing healthier means of coping with negative emotions, addressing some of the depression and anxiety that goes with that, and decreasing perfectionism and black and white thinking. And what he doesn't do, because he doesn't treat diabetes, is he doesn't apply that to blood glucose, but I sure as hell do. And I think that that's really important. And so we talk about, trying to really use, one of the strategies I use a lot is instead of focusing on the individual number, I have my patients, once they are actually taking some blood sugar checks, I have my patients look at the 30-day and the 14-day average on their meters. So a couple of the meters only give you a 14-day and a 7-day, but most of them will give you a 30 and a 14 and a 7. And so you'll be able to actually see incremental progress over time. And so, and sometimes that incremental progress is just the N. So you'll see the number, gosh, so last week you went from 7 checks in 7 days to 14 checks. That's great. You know, sometimes it requires that kind of distance, not evaluating the numbers themselves, but just the actual frequency of checking. And I mean, obviously, twice daily checking is not the ultimate goal, but we're looking at incremental movement. And so then I'll focus also on, you know, gee, if you look at your 30-day average, it was 350, but your 7-day is 250. So look at what's actually happened. And the A1C isn't even going to reflect tremendous change yet because it's 30 days. So, you know, trying to take sort of a smaller picture in a way, a smaller picture than the A1C, but a bigger picture than the individual blood sugar number itself. So I think that's actually a helpful tool. So when we look at the research on cognitive behavioral therapy in eating disorders outside of diabetes, what we see is average symptom reduction of 75%. So that's not a cure, but that's quite a bit of a symptom reduction. And abstinence rates are modest at best with an average of 40%. So we have to move forward. That's not where we want to end up. It means people are still struggling with this for years and years. But the combination of cognitive behavioral therapy with psychopharm, so with antidepressant treatments or some mood stabilizing treatments or anti-anxiety medications, is more powerful than either of those alone. And what's interesting and what hasn't been studied is the combination of improved blood sugars. So if you think about the mood impact that improved blood sugars have, no one's studied, if we don't even use psychopharmacology, if we just aim at improving blood sugars and the cognitive behavioral therapy, what happens then? There probably is some neurochemical and other impact that we could show, but we haven't been able to study it yet. So there are very few treatment outcome studies of eating disorders and diabetes at this time. In fact, there's one, and I'm going to tell you a little bit about it. But it's sort of this weird hybrid kind of study. It's a great study. I don't mean to knock it at all. It's the first of its kind, but it intended to be a treatment study, and actually what I think it proved itself to be is a prevention study. So what they took, this is the group in Toronto again, they took 85 women with type 1, and I should actually say young women, so ages 12 to 20, and they randomly assigned these young women to 6 weeks of group psychoeducation on eating disorders and diabetes. And one of their parents needed to come as well, and they ran separate tracks. So they had 6 weeks of psychoeducation groups for the girls with type 1 themselves, and then on the same night, but in a separate group, parents attended a similar kind of intervention. And then they compared that to treatment as usual. And what they found was that they were able to decrease self-reported dieting and body dissatisfaction, and they were able to decrease what they call the drive for thinness, which is actually just a portion of a questionnaire that's a diagnostic questionnaire for eating disorders in the PE group. PE is psychoeducation. But there was no difference in binge episodes or insulin omission rates or A1C, and they actually stacked the deck against themselves. So these guys are really, really interested in prevention. And so there were very few women in this sample who even said that they did take less insulin than they should. So it's hard to change a symptom that they're not owning up to yet. So there's some kind of trickiness in the cohort. But when you look at the bottom point, the A1C level was the primary pre-treatment difference between what they called responders and non-responders. So going into the 6-week intervention, 6 weeks, 1 month follow-up and then 6-month follow-up, Going into that intervention, people who improved in terms of their dieting, their body dissatisfaction, and their drive for thinness had an average A1C of 8.2. And people who didn't improve, who were considered non-responders, had an average A1C of 10.2. So I would say the horse is already out of the barn for the 10.2%. And what they did is they actually crafted some form of a prevention study. And so I think there's tons we need to do that moves beyond this, but it certainly has something to show, and I'm really pleased that there's at least some attempt at treatment. So the treatment that I most advocate for is, first of all, early detection and early intervention, because we know from the eating disorders literature in general that the best prognosis is with the shortest duration. And the Toronto group would advocate even for subclinical, so intervention at a subclinical level. So even before you're at the eating disorder NOS kind of category, when you're just maybe a teenage girl who has some body image concerns, that's where that group would advocate we've got to intervene, because this is such a high-risk situation in type 1 diabetes. The patient, in the kind of work I do, takes a very active role in treatment, and so she defines what she wants to focus on first. So if you think back to that model, if she's interested in first and foremost targeting the blood sugars, then we start with how are we going to increase frequency of blood sugar monitoring. If she wants to focus on improving the depression, I get her an appointment with a psychiatrist and we start on psychopharm. If she wants to start with her binge eating, we start right there where I talked about, with sort of creating an eating routine and establishing that first and foremost. And oftentimes they don't know where they're going to start, and so I just sort of throw these ideas out and we do a little bit of everything. But the treatment requires a multidisciplinary team. I'm really, really lucky because I work in a building where that already exists. So I've got, the endocrinologist, the nurse educator, the dietitian, the exercise physiologist, all of whom I can refer to, and I even have a psychiatrist, which is fabulous. So we've got that multidisciplinary team. It's a lot harder when you don't have that, and I certainly do get referrals from patients who get their medical care elsewhere, and they're just coming to Joslin to see me, and that's just a lot harder. They'll get monthly medical and nurse educator appointments, and sometimes weekly dietitian appointments right at the beginning. I happen to work with one dietitian specifically, so she and I think similarly, and we sort of have similar philosophies, and so that works very nicely. Regular lab and weight checks, that's done obviously by the medical team. And I don't do treatment unless it's already understood that all of us are communicating and talking about things regularly. And if the patient isn't open to that, then I can't treat that person. Treatment goals are established again through this collaborative kind of effort, and I think that's really important. Part of the reason why it's so important to have open communication between team members is that you want to all have the same message, right? So if I'm talking about incremental changes, but the endocrinologist, and this is just to pick a straw man as the endocrinologist, not that they're bad people, but if that person is focused on 7% A1C or nothing, we're talking two different languages. And so we're not a treatment team. So we have to sort of start to develop a similar philosophy. The goals are small and incremental and attainable. So think about that woman who talked about her lasting recovery. She sort of ticked little pieces along the way. And the DCCT goals are not the goals for these patients yet. We're not moving from a 14% A1C to a 7% A1C. It's just not reasonable. And actually, it's not safe. So I had a patient who did that because she was so hell-bent on not seeing the shrink again that she was referred to me as a 16-year-old with an A1C of 14, and a month later, she had an A1C of 7. And everyone was terrified and immediately rushed her to an eye exam because they were so scared that they had created some sort of havoc. Luckily, she was absolutely fine. But we try not to make moves like that because it's actually far too harsh on the body. And not realistic. She's now a very long-standing patient of mine, and it's been a long journey. So you have to find a goal that you can all agree on and incrementally focus on both the regularity of insulin dosing, the regularity of blood glucose monitoring, and again, the regularity of sort of establishing an eating pattern. In a way, I should have focused on this first. My initial hurdle, though, is that for the people who are in recurrent risk of diabetic ketoacidosis, that is my starting point. So if they've had multiple DKAs, that's the first order of business. I can't do treatment if the risk is they're going to be in the intensive care next week. So I try to get buy-in right there. And so, okay, we're going to establish the first goal of treatment is you're going to be willing to take your basal insulin with regularity. Because in order for us to even start treatment, we need to know that medically you're at least safe-ish, if you know what I mean. And so we discuss what the signs of DKA are, because a lot of times these women have symptoms of DKA or symptoms of ketosis, not necessarily full-blown ketoacidosis, and they attribute it to other things, and they just sort of drink extra water and move on. I had one patient who herself was a physician, and her A1C, I believe, when she started with me was 18, and she was drinking a gallon of water every 2 hours to try to flush the ketones. And basically, I mean, that's an extremely unusual circumstance, but she was functioning sort of as her own intensive care unit. So then we have to establish what are the common hurdles of the initial phase of treatment. And JJ gave us a clue in that diary entry. So insulin edema is really where my brother's actually right, and this problem really is diabolical, because at the very, very start of treatment, you're taking a patient population who is acutely concerned with how tight the waistband of their pants are, how puffy their ankles are, how puffy their cheeks are, et cetera, and you're actually giving them puffiness, right? You're giving them water retention. And they perceive that as fat because the number on the scale has gone up. And in fact, their skin feels tight. I mean, they really feel uncomfortable. It's a horrible feeling. And so we have to talk about that before any change even starts, because if I don't talk about that, I'm never going to see them again. So I would advocate that we need to start talking about that with most people when they're in intensive care for DKA. I mean, not when they're in intensive care, but once they've become medically stabilized and can actually talk with us, we need to explain to them what that weight gain was all about and why their body feels so uncomfortable and how they're going to get through that by actually allowing themselves to maintain appropriate hydration and maintain reasonably healthy blood sugars so that they can get through that to the end of that tunnel. The other thing that's really diabolical is the enlarged or fatty liver. So you do have patients, because they've had such prolonged exposure to high sugars, they actually have fatty liver. And their liver is actually swollen, and even though they're relatively quite thin, their abdomen is distended because of this enlarged organ. And I had a patient just recently where she actually was at an art festival where for some reason they had massage therapists, and the massage therapist said, "Oh, we're pregnant," and she sunk into the floor. So it is visibly noticeable, and so we have to acknowledge that for some of these patients, there's actually not a distorted body image. There is something that's changed in their bodies. Hypoglycemia is another trigger. So again, some of these patients are profoundly afraid of hypoglycemia, partly because they're afraid of hypoglycemia. It's a horrible thing. But partly because they're afraid of having to eat to treat hypoglycemia. And in the state of hypoglycemia, many, many patients will talk about over-treating their lows because there's this sort of frenzy of if some is good, more is going to do the trick, and how do I just get this feeling to go away? And that can feel a lot like a binge to someone who actually is a binge eater. And so that can also be quite triggering. And then one of the things where I really rely on my medical colleagues is that to try to well, the way I teach this to patients is, because of chronic hyperglycemia, there's this situation where their bodies have glucose toxicity, right? So they're not actually able to utilize their insulin as effectively. So the amount of insulin that it takes to sort of yank those numbers down into a healthier range is a lot more insulin than will be needed to maintain healthier numbers. And patients get that if you explain it to them, and they'll sort of have this aha, like, oh yeah, that's why I gained so much weight when I came out of the hospital, because I never had that adjustment within the first few weeks or first month. That they break through the glucose toxicity, and they really need to sort of take less insulin, but in a guided way by a medically trained person to help them avoid having to eat toward their insulin dose. So that's huge. Another really important thing is to address perfectionism, and I would say that's almost as big a problem with the patient as it is with the multidisciplinary medical team. We all have perfectionism. We know that this is a high-stakes disease, and we know that that the clock is ticking and complications are real, and so we've got to sort of keep out of our own way by not getting so perfectionistic that we lose sight of the incremental changes that patients are making, because those changes are real and they're important. And so we have to set realistic blood glucose goals and realistic self-care goals. We know that depression and anxiety are at higher rates in type 1 diabetes, happen to be at higher rates in type 2 as well. So we have to be alert to that as a potential complicating factor, and we want to treat that with all the tools in our armamentarium. We know that treatments work. I mean, these are highly treatable problems. And so typically I try to sort of destigmatize the idea of psychopharm by talking about the higher rates in type 1 and saying, hey, this is a very common struggle for people with type 1 diabetes. And then the fear is, yeah, but if I take the medicine, is it going to make me is it going to make me gain weight? And so you have to be able to know that you're referring to a psychiatrist who's sensitive to that issue and who's going to pick relatively weight-neutral medications. And then, of course, this is sort of the psychotherapeutic aspect that I work on more once we've got some of these other symptoms settled down, which is to talk about safer coping strategies when people are feeling triggered to either binge or purge or underdose or engage in or calorie restrict, engage in all these behaviors. So that's sort of the longer term aspect once some of the dust has settled. And I believe that's it.